Good afternoon. This is Shankar Roy. I am going to present my proposal regarding integrating housing instability data into population health informatics system in Shelby County at the Tennessee. So this is one of my proposal which comes from one of the course which is health informatics is course. So I developed this proposal for one of the course requirement. The main problems of the housing instability is well documented. Social determinant of health, which are actually not integrating in clinical care, as well as individual experiencing homeless or severe cost burden face higher morbidity, increased emergency department utilizations, and worse chronic disease outcomes. Despite this effect, housing, health, and social service agencies in Shelby County operate in separate informations to improve these informations, but there are some gaps which identified in these proposals to bridge this gap. The main objective of these proposals of housing instability data integration platforms is designed to bridge the gap between housing and health data systems, enabling proactive, equity-centered populations health management in Shelby County. There are three pillars of these proposals. One is integrated data sources, and second one is enable risk identifications through identify individuals and population at elevated risks before crises are escalated. And third one is support cross-sector coordinations. I developed the proposal system architectures, and which are four pillars of the architecture. One is data integrations, second is FHIR based standard, third one is analytics and dashboard, and fourth one is closed loop referrals. And health data instability housing infrastructure architectures is an independent pillar that transform the objective and actionable population health intelligence. Now talked about the data flow, which comes from sources to actions. How do we integrate data flow to unified housing instability platforms? First, we have use community based data. Then we will go to hospital setting, clinical, electronic health record screening data, and then we utilize the data in administrative evictions, and finally we will be use housing system data. So this proposal will integrate data from four complementary source streams, transforming raw, disconnected records into a longitudinal, person-centered housing instability profile that inform both clinical and public health decision making. One of the main characteristics we have follow privacy, ethics, and equity safeguard. And this proposal also ensure the permissions are granted by rules and agency, and we will data minimizations using minimum necessity data element which are collected by trained and reducing re-identification risks. And third one is aggregated and de-identified dashboard which will be support population level analysis without exposing the individual record. And for the equity safeguard, we will develop algorithm output which are audit for or to discriminations to bias as from the socioeconomic and prevent the disparity. The anticipated impact and evolution framework are actually a key equity goal, which will be reduce disparity in referral completion rates across race, income, and geography within 18 months of development. In within 18 months of development, and we will be developed data quality checking, risks stratifications, referral tracking, and equity monitoring. At the end, yes, so I can tell you housing instability data remain one of the most under-integrated domain in American public health informatics, despite its outsized influence on population health outcome. So by this implementation of this project, we will ensure to close the critical gap with housing data, which is systematically excluded from clinical and public health workforce, leaving the most vulnerable population invisible to the system designed to serve them. That's it of my presentation. Thank you very much for your listening.